about something which is similar but which nobody likes, which are mortality and morbidity meetings. I don't know how many of you have had such meetings when you were doing your MD, your MD classes and your 3 years MD courses. But many hospitals do have them, and they are also an essential part of good clinical medicine. The important thing is to take mortality and morbidity meetings in the correct, you should think of them as a learning exercise and should not think of them as an exercise in which somebody is going to poke fun at you and deride you. It's not like that. These should be, these are exercises for learning, and usually there is a person who is always a senior faculty who is always comparing these meetings, and they will ensure that these meetings are done in a proper manner. And so the mortality and morbidity meetings are a little different from case presentations. Here the emphasis is on the event which led to the mortality or the specific morbidity. And I'll just go through in our department, for example, we have monthly mortality meetings in which all cases there's been a mortality, they are discussed, and 1 or 2 cases which have unusual mortality, they are discussed in more detail. And the institution also has mortality meetings every last Saturday of the month. It's not been happening in the last couple of months because of COVID-19, because of COVID infections, but it's going to restart, I'm sure, in a short while. So you should be prepared for these meetings also. So like I mentioned, these are essential part of academics. And the aim when you present these meetings is to be thorough with the patient, what happened. Present details which are details leading up to the terminal event. Be honest with the sequence of events and what exactly happened, and what can be done in the future to, if at all anything could be done to prevent the morbidity or mortality, and to present some key learning points. And one should be prepared with answers and not be on the defensive. Being on the defensive never helps. So some general points, not only for mortality meetings, but also for other meetings, is do not identify the patient by name. Avoid such that you can, by face, the patient can be identified. And in mortality meetings, it is always good to invite other departments who have been involved in the care of the patient to comment, either take part in the presentation or to comment at the end of the presentation. This has been taken in so much detail. I think I will, if I keep it here, then Dr. Afzal will say that I didn't do this properly. So I'm going to not show this slide. So this is the scheme in which normally mortality meetings are presented, or the cases presented. There is usually a patient report. And in this case, it is usually a brief case summary. One should mention all the comorbidities. Like I mentioned before, the emphasis is on the events which led to the adverse effect. So you present the comorbidities, whatever were the investigations, what was the admitting diagnosis, and what was the management of the patient and the course of the patient in the hospital. And course of the patient sometimes is very long. In many of these patients who have had unfortunate a fatal event. So in that case, again, it is better to present them as graphs or tables rather than to present them on day 1, day 2, day 17, to day 19 like that. It's really very tedious for people to hear that. And then the emphasis is on the event, and one should give more details of the events which finally led to the mortality. The event itself should be described in detail. How it was managed should be described in detail. And after that, there should be an analysis. That means, were there any errors or otherwise which led to the event? For example, there may be some human errors. The doctor or the resident or the consultant may have misinterpreted the reports. There may be a diagnosis which was not considered. Maybe the treatment was inadequate. Whatever it is, in hindsight, you can always do an analysis and present it. There may be systemic problems. Many times we find that patients, some equipment was not working, and if it was working or not available, we are not able to shift the patient to the ICU or to another ward where it was needed because those ICUs was full. There was no way that the patient could be shifted. Certain drugs were not available at night. So the patient had poor monetary resources, which is often very common in India. They were not able to afford certain procedure or certain drugs. All these are part of your analysis. And finally, there may be comorbidities which led to a poor prognosis. For example, old age, diabetes, cardiovascular disease, etc., etc. At the end of the analysis, it is good to, if you wish, to have a short review about the illness and the cause of mortality if it is totally relevant to this patient, but not more than a few slides. This is not the forum for you to present a 15-slide review of literature. Just very relevant, 2 slides, 3 slides, you want to show that such a patient, if he presents, this has been the knowledge, this has been what is known in literature, that if such a patient comes with these kind of this disease with this clinical features and morbidity, this is the mortality. And then finally, you present the key learning points. And usually the discussion for this is conducted by a different consultant, often a senior consultant, and they try to make the discussion balanced so that it's not it's not a session where there's lots of incrimination as to what happened and why somebody did not do this or did not do that. And that is usually the effort in these sessions. And you should try to answer the questions honestly and do not be on a defensive. If there are any mistakes, should admit these mistakes. If there are none, one should just say that there were no mistakes. This is the prognosis of this patient. And finally, one should always mention what you have learned from the case and how one could manage this patient in the future if a similar patient presented. So in the end, I'll say that mortality meetings are a learning exercise to understand what went wrong, how did it go wrong, why did it go wrong, what can we do differently in the future. and what are the key lessons at a larger organization level? Is there something that we can all do better? I think that's the end of my presentations, and I'll be happy to answer any questions if you have